Welcome to this week's presentation. We have two different categories of diagnoses that we are going to look at today. We are going to look at neurodevelopmental disorders as well as disorders in the schizophrenia area. So first we're going to start with neurodevelopmental. And part of why we're starting here is, again, we're looking at the DSM in a lifetime perspective. So things that happen earlier in life are going to be earlier in the DSM in general. And the neurodevelopmental category is going to be that category of diagnoses that typically will come up very early, often before the individual enters grade school. So these are the conditions with an onset in the developmental period. There's going to be a range of developmental deficits that will vary from very specific limitations learning or control executive functions to global impairments such as social skills or intelligence. Keep in mind that neurodevelopmental disorders can often co-occur, so there's often going to be more than one at the same time. So for example, individuals who have been diagnosed as being on the autism spectrum often have an intellectual disability disorder at the same time. And similarly, many children that have ADHD also have a specific learning disorder. So you're going to want to make sure you're doing screenings and making sure that you know if there's more than one thing happening at the same time. In some of these disorders, the clinical presentation will include symptoms of excess, as well as those deficits and delays in achieving expected milestones. So, for example, autism spectrum disorder is diagnosed only when the characteristic deficits of social communication are accompanied by some of those excessively repetitive behaviors that can include restricted interests and insistence on sameness. So here is our list of all of the different diagnoses in this category. And as we go through all of these different categories, we're not going to have a slide and discuss each one individually. Some of these things are very specific and you will very rarely see them. Some of them are very general and are really only used when other things don't fit. For example, the unspecified neurodevelopmental disorder, we don't really need to talk about that. That's going to be what you use when nothing else really fits, but you need that diagnosis, whether it's for insurance purposes or whatever. But most of the time, you're going to fall into one of the categories that you see more frequently. So again, if we are looking in the DSM-5-TR, we're going to start this section on page 37. We're going to start looking at the intellectual developmental disorder. That is our first one that we're going to see. This one is characterized by deficits in general mental abilities. So that could be reasoning, problem solving, planning, abstract thinking, academic learning, lots of different variations. There's also going to be an impairment in adaptive functioning so that they have trouble fitting into different situations. They have trouble adjusting when something is new or unexpected. This is about 10 per 100,000, and a severe prevalence would be about 6 per 1,000. It is non-progressive, so it's not something that's going to get worse over time. It's going to stay fairly stable. It is important to note that people who have this diagnosis are very much at risk of victimization. So they often might not understand that they're being taken advantage of in different situations. There's also that high risk of suicide, as we see in many, many, many diagnoses that we're going to talk about this semester. So we're always going to have that risk of suicide kind of in the back of our head. And if there's any kind of red flags coming up, please do that assessment. So the intellectual disability disorder, again, something that's going to stay the same for the person's lifetime, but it is something that you're going to see starting early on in very young children. You're only going to have this come up for an adult as something new if there's been some kind of illness or injury that has affected the brain. Communication disorders, you'll see starting on page 46. This includes language disorder, speech sound disorder, social communication disorder, and childhood onset fluency disorder. So these are like other neurodevelopmental disorders, and the communication disorders begin early in life, and they can produce lifelong functional impairments. This is one that, with some support and treatment, can improve over time, but is often something that can be a challenge throughout the person's lifetime. The biggest one in this category that you're all very familiar with, at least in general, is autism spectrum disorder. So we have this little umbrella picture here because this is what it looks like now in the new DSM-5. In the DSM-4, we had these three different categories that were all kind of under this umbrella that are now in the DSM-5, one diagnosis, the autism spectrum, and might have a different specifier instead of a different diagnosis. So the biggest change has probably been that Asperger's disorder is now combined into the autism spectrum disorders. It was separate from autistic disorder. It is now in the spectrum. That has been one of the biggest challenges for some people, a shifting in their identity. So if they had previously thought of themselves as, I have a diagnosis of Asperger's, and now they're being told they're under the autism spectrum, that can be very challenging. And I think I just said most of the things on the slide because sometimes I do that. That's okay. So this is one of the biggest changes from the DSM-4. I do want you to note that the 4 is spelled out with Roman numerals. DSM-5 has our normal number 5. So make sure you're looking at that when you are writing things down. Autism spectrum disorder in general is characterized by persistent deficits in social reciprocity. Nonverbal communication behaviors are used for social interaction, and the skills in developing, maintaining, and understanding relationships are often challenged. There's often a presence of restricted or repetitive patterns of behavior, interests, or activities. And as we said, there are many, many, many specifiers. So page 58 is where you're going to start to go to look at those different specifiers. There is a clear evidence of deficits in the ability to engage with others and to share thoughts and feelings, especially in young children. With adults, we're going to see difficulty responding to social cues, and there can be intellectual impairment or language impairment that does not need to be. So when everything was only when it was separate, when it was autism and Asperger's, typically, but not always, the people who had the diagnosis of autism were a little bit more nonverbal. There's often more behaviors, such as, there's often a lot of different behaviors with that. Whereas we see differences with the people who have Asperger's, who might be very verbal and just not have the social cues as we might expect. And do note the way the DSM-5 is written out here as opposed to those Roman numerals. So in our DSM-5-TR categories and criteria, our prevalence is between 1% and 2%. Symptoms are often seen about during the second year of life. It could be a little earlier or a little bit later. And you might notice a lack of interest in social interaction in those first couple of years. So as opposed to a normally developing child who might be seeking out attention, there may be a lot of just that lack of engagement that you would expect. There are definitely situations where there are developmental regressions, especially in that first 2 years. So it's not all that uncommon that you'll have a child who's developing in a fairly healthy neurodevelopmental pattern until about the age of 2, maybe 2.5. And then all of a sudden they regress. And even if they were interacting with their caretakers very well, engaging, have eye contact, all that kind of thing, they might stop those behaviors into that regression and not want any engagement with those caretakers that they were previously very engaged in. So that is something to keep in mind. I know I worked with a child in Hawaii that was about 3, and his mother was a special education teacher, so she knew exactly what to look for. and she had no concerns. There were no issues with this child and his development in his first 2 or so years of life. And then all of a sudden, he really severely regressed. And I'm sure that was very difficult for that mother because she knows how difficult it can be to work with someone who is very severely on that autism spectrum, and he was pretty severe, the child. So it can absolutely happen where there's normal development and then a severe regression and a diagnosis. Interesting comorbidity with epilepsy that tends to be correlated with lower intellectual and verbal abilities. This is also 3 times more likely to be diagnosed in males. So I'm not going to spend a lot of time talking about this, but I did want to have a little bit of at least a slide noting that we really don't know the exact cause of autism spectrum. There is some research that is suggesting that is a combination of genetics and environment. And you can read a little bit more on some of that on this slide. So what you're going to sometimes hear, oh yeah, sorry, here's the environmental section. Environment refers to anything outside the body that can affect the health. There's some people who are thinking that a lot of the pollution that is coming into our current environment might be a part of that. Complications during birth, parental age, other demographics, exposure to toxins might be a big one. Here's the one I was looking for. So we've all heard that there's that assumption or fallacy that autism spectrum disorder is connected to vaccines. So that all came about because of one article that was published by a scientist who kind of intentionally shifted the information, and it was not a positive research study as far as actually proving any kind of correlation between vaccines and ASD. Unfortunately, that was picked up by a lot of other authors who were citing this one article that was not correct information, and then it became this myth that vaccines are what cause autism. So you're still going to hear this in a lot of different pockets of people. So just be aware that that has been disproved, but it is still a pretty strong belief in many people. There's a link here if you'd like to take a look at the story. I just looked at TED Talks that I really enjoyed. And I'm not going to play it, but it is in the PowerPoint without the video if you'd like to go in and take a look. ADHD is probably the other neurodevelopmental disorder that you will hear about and see quite a bit in your practice. So this is defined by impairing levels of inattention, disorganization, and/or hyperactivity and impulsivity. This will begin in childhood. There will likely be several symptoms before the age of 12. It is kind of difficult to diagnose in adulthood. It can be very unreliable at that point in time, although I certainly have had clients and know multiple adults who are still diagnosable as ADHD. Sometimes there's some mild language delays, motor or social developmental issues. Again, high risk of suicide, especially if those comorbid diagnoses are there. So again, you're always going to have that suicide risk kind of like mindset where you're always going to be looking for that and then do more thorough assessments if any of those little red flags come up. In children, there's the prevalence of about 5%, about 2.5% in adults in most cultures. And there are a big combination of behaviors and symptoms, so make sure you take a look at that on page 68 in your DSM-5. A specific learning disorder could be diagnosed, again, typically early in the years of schooling, if you see a specific deficit in an individual's ability to perceive or process information efficiently and accurately. And that's one that if you're working in schools or again with maybe elementary school children, you're going to want to be a little bit more familiar with. There's also neurodevelopmental motor disorders that can include developmental coordination disorder, which really looks a lot like clumsiness. Whenever there's some kind of clumsiness going on, I also Look to do some trauma screening. Sometimes being very uncoordinated in the physical body comes from a discomfort in the body due to trauma, making the body not be a safe place. That does not mean that this is always true with this diagnosis, but something that I would always look for and screen for. There's a stereotypical movement disorder that will be repetitive, driven motor behaviors like the hand flapping, and tic disorders, which could be vocal or movement oriented. The other category for this week is the schizophrenia spectrum. And this is going to be defined by abnormalities in one or more of the following domains. There might be delusions, hallucinations, disorganized thinking or speech, grossly disorganized or abnormal motor behavior, or negative symptoms such as a diminished emotional expression or avolition. So there's a lot of different things that you're going to be looking for in this spectrum. And in this spectrum, you're going to always, just as we've talked about in class, with every set of diagnoses, we want to diagnose the least severe or the least stigmatizing. So start with something small, and then when you know more, you can bump up that diagnosis if you need to. Here's our spectrum listed below. We have quite a few different diagnoses. Personality disorders we're going to look at later on in the semester, but the schizotypical personality disorder does fall into the spectrum. We have delusion disorder, that is 1 month, but no other symptoms. Brief psychotic disorder, more than a day and less than a month. Schizophreniform, they're kind of similar to schizophrenia, but last less than 6 months. Schizophrenia is going to be at least 6 months with 1 month of active symptoms. Schizoaffective combines mood episodes as well as some of those issues such as hallucinations or delusions. And then psychotic disorders induced by other conditions might be medical, might be substance use, that kind of thing. So we have quite a spectrum going on here. The one we're going to probably see the most is schizophrenia. So you can take a look at that starting on page 113. If you are looking at schizophrenia as a diagnosis, rule out schizoaffective disorder, depressive disorders, bipolar with psychotic features. So bipolar 1 can have some psychotic features. Again, we'll talk about that a little bit later on the semester. This can include a range of cognitive, behavioral, and emotional dysfunctions, and has to have impairment in one or more major areas of functioning. You might often see inappropriate affect, disturbed sleep, depersonalization, somatic or body-based concerns, slower processing speed, and other deficits, and often a lack of awareness. So even if they know that they have this diagnosis, it might not have much meaning to them. For some people, but definitely not all, it could be associated with hostility or aggression. Most of the people that I've worked with that had a diagnosis of schizophrenia were some of the nicest, gentlest people, but that does not mean that's always the case. It is important to note there is no medical test to determine schizophrenia, just like with all of our other diagnoses and as we've talked about. Differences can actually be seen in different brain regions, which you'll see in this slide here. I'll go back in just a moment, but you can actually see that the brain matter in the brain has some differences. So we see a couple of things. There might be different amounts of the chemicals that are associated with the transmission of nerve impulses. There can be changes in the frontal lobe, which is the part that does that executive functioning, that thinking, processing, all of that. The hippocampus and some of the areas around that can be smaller than usual. That can affect the sensory input that's taking place. And the ventricles can also be larger than normal. That can put some pressure on brain tissue. So there is actual brain changes that we can see if someone actually goes in and does some scans. These are not conclusive though, so they're still there's no definitive medical test, even though sometimes we can see in scans differences in those brain regions. Lifetime prevalence of 0.3 to 0.7. Those psychotic features will often emerge sometime between late teens to mid-30s. That lower age is going to mean a poorer prognosis. So the earlier in life this happens, the more severe it often is. Over time, and this is a very long-term time, those psychotic symptoms tend to diminish and decrease over the life course. So if you're working with someone who was diagnosed when they were 25 and now they're 65, their symptoms, their psychotic symptoms might be much less severe than they used to be. There is a strong contribution for genetic factors, but that does not mean that this is a purely genetic diagnosis. Typically, the way I think of this is that the genetics will make them predisposed to having a diagnosis for schizophrenia, but then some kind of traumatic or stressful event will actually push that person over into the actual diagnosis. There can be complications in pregnancy and birth, and a greater paternal age, maternal diabetes, lots of things related to that associated with the diagnosis. There are slightly fewer females diagnosed with this, and it is something that will be diagnosed often later in life if it's a female. Again, high suicide risk. With all those hallucinations and delusions going on, this makes a lot of sense, especially if there's that comorbidity with substance use or depression. So make sure, again, you're looking at all those different areas of things. Lots of comorbidities in this one as well. Schizoaffective is going to be similar to schizophrenia, but it's also going to combine a major mood disorder, depressive or manic. So just keep in mind that it could be, you're going to want to tease out the difference between the two. You're going to want to look for those mood disorders. Occupational or social functioning is frequently noted as being impaired. This is not as common as schizophrenia, so it's about a third, and it's usually going to occur only in adulthood. And that is all for this week. So have a great week. We will get into our next few topics next week.